it looks like it's going to rain all week, or most of the week. All right, so some housekeeping stuff. We're going to finish up fibrosis, healing, and tissue repair today. And then we will start immunology on Wednesday and finish it on Monday. And your first exam is a week from this Wednesday. Okay? So that's on the syllabus. We're right on schedule. Next week you don't have a pre-quiz, you don't have a post-quiz. Congratulations, you get the week off. However, you have an exam on Wednesday. Okay? So not really you get the week off. But any questions about format of the exam? You guys want to talk about that? Okay. So it's going to be 50 questions, multiple guess, multiple choice, depends on how much you study, I guess. And we'll take it right here. We'll have proctors. Ryan and I will be the only two answering specific questions about the exam. It doesn't hurt you to ask the question. But I don't want you to be offended if we say, well, we can't really answer that, because that's actually what the question is asking, right? So the question's, about, apoptosis, and you ask us, can you explain what this word means? But that's actually what the question, do you see what I mean? So don't be offended if we say we can't answer that, but it doesn't hurt to try. As long as we're on that same page, where you're trying to ask a question, and we're going to tell you yes or no if we can answer it, you might as well try. There'll be other proctors in here just kind of keeping the flow going and how to turn in the exams. You'll see we have a couple of versions of the exam, so it gets a little crazy because you guys are brain dead by the end. Version 1 goes into the version 2 box, and then everything's all messed up. So I'll help people help with that. There will be some questions on the screen. That'll be images. So those might be gross images, they might be histology. They will be familiar images. Okay, they won't be like some biopsy I collected last week, sliced it up, and I took a picture and I want you to tell me what it is. We won't do it that way. You'll have seen these pictures before. Or these images before. If you're an honor student or a graduate student, you'll have some essay style questions. For those of you that are not in that category, you don't have to worry about it. They'll be on the exam, you can ignore them. And I'll mention that again. You're like, what? Ignore questions on an exam? If you read the instructions, it'll be clear, but I'll remind you of that on Wednesday of next week. Any other questions or comments about the exam? Yes? Good question. Are any of the pre or post quiz questions going to show up on the exam? Not intentionally. So I wrote all those questions. So, if you love them, I did it. If you hate them, I'll blame a grad student. But I won't go to the test bank and try to find one of those questions and then recycle it. I write the exam. The way I write the exam is I sit down, typically like on a day like today, I'll have like a cup of tea or a cup of coffee, and I'll pull up my lecture notes. And I will literally cruise through my lecture notes and select topics that I want to write questions about. I'll write questions about those topics. Okay? I don't open up the book and try to find some obscure, italics font that nobody read. I don't go to the test banks that you've already had, find the one that was the most frequently missed question and put that on the exam. I literally write from my lecture notes. And that's why I'm telling you the lecture content is the most valuable of the class. And that's why we go through the energy of recording the lectures and posting them, because I think it's a great way for you to study. Okay? Other questions? Those are good questions. No other questions? You guys are ready? Should we just take the test on Monday? Oh, okay. I was just making sure you had a heartbeat because you guys were paying attention. Okay. So next up, let's talk about, what goes up and never comes down? High blood pressure? Well, you can medicate, right? Non-exam weeks, it's lower. What's that? Age. Who said it? Age. Very good. All right. Keep in mind, this one makes me chuckle, just because of the phase of life they were in. What is black and white, black and white, black and white, and green? What is black and white, black and white, black and white, and green? 3 skunks eating a pickle. Come on. Hey, Thunder is so funny on that one. I mean, that was really funny when you think about it. Like, you're like, oh, this is going to be hilarious. Yes, it's funny, but we are laughing at you. What type of dinosaur does things really quickly? Velociraptor, I like that. Might be a little bit above the age group, but that's pretty good. That's pretty good. A Prontosaurus. I do like Velociraptor. I love that. Okay. All right. So this lecture is really fun for me. This particular one, because, and I promise you, not every section of this class where we have a content, am I going to start showing my research? You know those classes where you're like, all of a sudden it's like 181 and you're talking about forest ecology, right? It has nothing to do with, you mentioned plants, and so now the professor's talking about all their forest ecology research. But I actually do a lot of work on wound healing, so it is relevant to this lecture. Now we get to cirrhotic livers, I'm not going to show you my research because I don't research that. But this one's kind of fun because it fits in, and I've been doing this a long time. So we're going to talk, and there's some pretty gory slides here, so I have a warning. And these wounds that I've been looking at for the better part of 20 years now. So I've been 2 decades worth of doing wound care research. And this one's pretty gnarly, pretty aggressive. But really, in this circumstance, the best treatment is going to be to approximate that wound. And you can actually see that wound approximating means you bring it together, right? You bring those 2 margins together, and then you would sew it together. You would suture it together. And you're going to have a pretty good outcome, although this is what's considered to be in the aesthetic zone because you can see it. And so there's going to be a pretty aggressive scar. But in certain circumstances, like this one, which is gory, this next picture, there is no ability to reapproximate the wound. Okay? This is a burn patient, and you're not bringing together any of the borders. It's just not going to happen. And so in that circumstance, when approximation is not always an option, we look at some alternatives. And this is the field of wound care. And the alternatives could be like autologous skin grafting. We're going to take tissue from cadaveric sources, and you're going to decellularize it, meaning you take the cells out. Why do you need to do that? What's that? Major histocompatibility complex? Yeah, the even simpler answer is the immune response, but that's on the MHC. We're going to talk about that Wednesday and Monday, so we're kind of alluding to that. So it's connected. The reason you take out the cells when you do autologous skin grafting, this is autologous skin grafting where you wouldn't take out the cells, I apologize. You would take it from one part of the patient and put it on another part of the same patient. Autologous meaning self, I misspoke. So if a patient has a burn on, let's say on their arm, they may graft part of the back side, take some skin there or off the thigh, and then put it on the arm, okay? So autologous means the same patient, so you don't have to decellularize it. I need to look at my notes a little bit more carefully. Here is where you have to decellularize, is when you have allografts. Allografts mean you take a cadaver, like I was mentioning, too early, I got excited. You take a cadaver, you remove the tissue, you decellularize it for what was said by Richard over here, right? Richard, okay. Or you could actually get skin from an animal. That would be a xenograft from another species. Xeno meaning different species. Allo meaning same species, but it's a different person, and then auto meaning self. So a graft from your own body to another location, a graft from a cadaver, or a graft from usually a pig or a cow. Pig would be porcine, cow would be bovine. Here you got to decellularize for the reasons that we were talking about a little bit earlier. Then this other category has started to come on the scene about 20 years ago when I sort of got involved. And these are commercial dermal substitutes. And one commercial dermal substitute that I was heavily involved in, but let me pause. Was there a question earlier?
It was about the decellularization of autologous aspect.
Yeah, but you don't need, I misspoke. Maybe that was, you're about to correct me. Nicely done. Okay. So where I got started was back in the 90s with a company called Advanced Tissue Sciences, and we were making these dermal substitutes. So we were taking scaffold biomaterial, like what we saw with the Vicryl mesh, or with the polypropylene is what is made up of Vicryl. And this polypropylene mesh, we would actually seed it with, we would populate it with skin cells, with fibroblasts. And we had a fibroblast covering, and then we remove the cells and leave back behind the scaffold, the biomaterial, and the matrix that was produced, and that was called transite. And then we had a product known as Dermograph that was the living cells that stayed. So it was fibroblasts on a Vicryl scaffold from another person, and we would culture it. It would create kind of a new skin. And that same technology I had developed for a cardiac patch technology called Antiinflammatory. And we're not going to talk about this one, and we're not going to talk much about this one. We're going to focus on this wound care product known as Dermograph. So human fibroblasts from a donor, and where do we get the fibroblasts from? These were skin cells that were very young, and we got them off of young patients. And they only came from boys. Any ideas? Foreskin. From circumcised tissue. Okay? So still plenty of circumcisions happening today and 20 years ago. And that's discarded tissue. So instead of throwing it in the trash, the biohazard, we actually would cultivate the cells out of it and then create this Dermograph product. So this is kind of schematically what it looked like. We would have this bioresorbable scaffold. It looked exactly like that polypropylene mesh. And we would see these fibroblasts onto it. They would grow, multiply, fill the spaces, the open spaces. They would make their matrix, which is kind of like these stretched out, look like little figures. That's the matrix. And they would make these growth factors that were soluble. That means that they went into solution. And that would happen over a period of like 4 to 6 weeks. And after that period of time in a bioreactor, you'd have a completely new tissue that was human. Now, one of the questions that we would get asked is, well, if you took cells from one patient and you grew them out and you implant this and you have the cells there, how do you get by the immune system? Well, the thing that was kind of cool about this technology that we had figured out is these were very young cells. They were neonatal, right? They were on the other side of being born. But when you grew them in a three-dimensional matrix, they created this matrix around themselves. It was almost a immune cocoon, and it would block the immune cells from seeing the transplanted fibroblasts, so they were immune privileged. All right, so this is a picture of a scanning electron micrograph that shows these big fibers. Here's a fibroblast, and you can see how it's stretched and hanging on to this, like the jungle gym analogy that I talked to you about a couple weeks ago. So these fibroblasts stretch across the spaces, they make their matrix, and they fill this gap. We have kind of a yucky picture coming up here. This is a clinical trial that we did. If you look carefully at the date, you can see December of 1995. That's when we were doing the study at UCLA. So this is the bottom of a heel, a patient's heel. And so up here at week 0, bless you, you can appreciate the size of this wound, and this ruler that's shown here is showing centimeter markings, right? So this is approximately like a 3 centimeter large wound. 2.5 centimeters is about an inch. So it's a little bit larger than an inch in diameter on the bottom of their foot, non-healing. One of the inclusion criteria in the study to be enrolled is they had to be unmanaged diabetics and have a chronic wound that was open for at least 6 months. So it's been sitting like this for 6 months. Can you imagine how painful that is? Well, the good news is they can't really feel it because they have neuropathy, meaning that their nerves in the distal part of their foot don't work anymore. Okay, we'll talk about that later in the semester of why that is. But this is a diabetic foot ulcer. Okay, that's what this is called. We place this dermograph patch on at every week interval that you see, and after 10 weeks, it was completely healed, completely closed. Okay. We used a technology known as laser Doppler, and this is a long time ago, so this was kind of like cutting edge stuff. We're still doing this type of work today. Now the scans are a little bit more sophisticated, but you can appreciate this is a different patient. This is 1 week, this is 2 weeks, this is 3 weeks, so the wound is still open. But you can appreciate that we've circumscribed the wound bed, and in the middle of the wound bed on laser Doppler, the cool colors mean low flow of blood, low blood flow. So like the blue and the black means there's not really anything happening inside the middle of the wound. And then after about 3 weeks of treatment with the dermograph, you can see that now there's blood flow moving into the wound, which is why the wound on the prior picture is starting to close, because you're increasing blood flow into the tissue, and blood flow, like we talked about, is absolutely critical for wound healing to be facilitated. So we played with this concept of perfusion quite a bit. And we looked specifically at VEGF production. VEGF is a potent angiogenic growth factor. And we had a little assay where this is actually a fertilized egg, a chick egg. It's called the chick choriantoic membrane assay, where you open up a little window and there's a membrane, the chorionic membrane, and you can actually apply certain substances to that membrane. And because it's an in vivo assay, it's a little chick that's growing, it'll stimulate blood vessels to grow if it's angiogenic. So it's a bioassay. Does that make sense? I'm going to show you some bioassays that we're doing now, today, in 2019, because we're not using chick eggs anymore. We've gotten a little bit more sophisticated. But this was a fairly robust assay. You can appreciate the control where the scaffold has, this is a control scaffold, no fibroblasts, there's no blood vessels growing within it. And then our dermograph technology on the bottom, where you've got large vessels and a network of vasculature that's a result of the VEGF production that happens in growing capacity over time. Okay? So we knew it had a very angiogenic material. Okay. This next couple of slides, they look bad on your printouts, but they look really bad on the big screen. Okay. So this was an accident that took place. This individual was actually cutting wood with a chainsaw, and it slipped. Okay. And so you can see exactly what took place. Was rushed to UCLA Medical Center, and the company at the time, we were down in San Diego area, in La Jolla, and so UCLA was kind of like the big trauma center that was nearby at the time in the 90s. And San Diego's grown a lot, so now they have trauma centers that are almost the same magnitude, like at UCSD. But patient was stabilized, patient was treated. Here, I'm going to dim this now that picture is gone. Patient was treated. They packed the wound bed full of the dermograft, and here's a picture 1 year later. Okay, 1 year later. So what I want to ask you right now is this an example of complete wound resolution, or is it an example of wound healing where you have not complete restoration of function? So talk amongst yourselves, turn to your neighbor, and which is it? Which is it? Is this wound resolution, or is this wound healing? right, let's hear some thoughts from our expert panel. Who would like to take a stab at this?
I say resolution because it looks like his hair is going back.
Okay. So up front we have a vote for resolution because, and she's sharing appropriately, it looks like he's got hair that's grown back over that area of the scar. Okay? I see some nods, so you have some supporters for your concept. Yeah. Maybe a different perspective?
Yeah, I would say when earlier you were talking about how it's kind of like a spectrum, like there's no
Okay.
such thing as like full resolution or like just only healing. It's like
Okay.
kind of along there, like you can see there's like still scar on the lip and like part of his nose has lost some structure, so that's would be an example of healing. But like she was saying, on like the upper lip, the mustache is growing back, so that part is as in resolution or like regeneration of tissue.
Does everybody hear that? Okay, I like that as well. Everybody make an argument for wound healing, where we've got significant scarring, fibrosis. Richard?
It's possible that we don't see any of the internal things that are going on here, so you
Okay.
might have loss of function in the lip or something
Right.
that's not indicated on the picture.
So it'd be nice, that's a good point, we got one still picture. I'd like to see this individual smile and see if maybe their right side of their face is droopy and muscle attachment has been compromised. We don't know. Very, very good. Okay, again, this isn't like, I will tell you when you're wrong, okay? But this is a situation where it's not a right or wrong answer. Like all three of you have made a very good argument for your answer. So this would be a horrible test question. Unless it was an essay style question, right? But in a class of 110, it's hard to do essay style questions. I do them for the grad students and the honor students. But I wanted to give you a sense of how we would write an essay question. And I put this picture up and say, so tell me what you think's going on. And all three of you could have gotten full credit if you would have explained it the way you just did and you justified it. And correct, that it's a spectrum. So I think we can see, it was nice, we had three answers, they were all different, okay? We had its wound resolution, and we had all the way to possibly fibrosis, and we don't see everything that's going on, right? And then we have somebody in the middle who's our politician that says, well, maybe it's both. Okay, I like it. So all of you did a really nice job there, but hopefully the point of this picture is for you to be thinking about the different aspects of healing. And for you to be able to characterize, yes, if there's restoration of function and you got hair growing back, that's something that we do see here. We do see some evidence of some fibrosis, and yes, we don't see the whole picture. We don't know everything that's going on. Any other comments or questions about this particular case? What if we had histology? Would that be helpful? Absolutely. If we have the histo, we can take a look microscopically to see, you know, is there muscle planes that are reattaching? But again, you know, this individual is just happy to be where he's at, probably not interested in that, okay? One of the limitations of clinical data is, you know, you've got a person that has to consent to whatever it is that you want to evaluate, which is one of the reasons that we use preclinical models, right? Okay, questions on that? So I'm transitioning, I'm flashing forward like almost 30 years. Let's see, let me count here. Oh no, not 30 years. About 20 years, yeah, about 20 years, okay, cool. Oh no, about 25. Right in the middle, 25 years. So this is a regenerative medicine company, a newer one, that became part of about 3 years ago. And the core technology utilizes, again, very young tissue. So back in the 90s, was playing with, right, that was the mid to late 90s, and we were playing with, well, that's a horrible way to say it. We were experimenting with human fibroblasts, skin fibroblasts, okay? Now you're all laughing, but you'll never forget where we got our fibroblasts from now, right? So we were experimenting, and I use the word playing with. We were experimenting with skin fibroblasts. And we were getting these from a very young skin source, and I told you why they're immune privileged. But now we've decided, well, what if we could get tissue that was a little younger than that? And there's some discarded throwaway tissue, and it can come from placenta. And so on the far left, you can see this is a picture or a schematic of a cesarean delivery. And so in a cesarean delivery, it's a sterile procedure. The placenta is the tissue that holds the umbilical cord to mom, and it's a very nutritionally rich tissue. It's also referred to as the afterbirth. So after the baby's born, then the placenta detaches and it comes out of mom a little bit time later. Okay, usually the obstetrician will help kind of facilitate that process with, kind of like abdominal massage to push it out. But in a cesarean section, it's sterile procedure and it's harvested. It's actually surgically taken out. Well, that tissue is typically discarded as well, just like foreskin tissue is. And there's two layers. There's a chorionic membrane and there's an amniotic membrane. The amniotic membrane is the mom side. I'm sorry, the baby side. The chorionic membrane is the mom side. Okay? Well, we take this amniotic membrane and obviously we test it for all sorts of different, it's got to be HIV free, it's got to be hepatitis free. The mothers are young mothers. There's a donor age limit, so we're not getting older pregnancies or pregnancies from older women that might be at risk. And it has to be cesarean. And then we decellularize the membrane and it becomes a graft material. And then we take the cells out of this membrane and we grow out mesenchymal stem cells. So these are mesenchymal stem cells. They come from the amniotic membrane. Bless you. Okay? So they're not embryonic, but they are really close. You guys get it? Super close. But they're discarded. They're thrown away anyways. In some cultures, they'll actually save the placenta and they plant it. Some cultures actually they consume it. They actually have ceremonies and they'll actually eat the placenta. Okay? So we utilize it to pull mesenchymal stem cells out, grow them in culture, and instead of using a fibroblast, now these are mesenchymal stem cells that release growth factors and cytokines into the culture fluid. We harvest the culture fluid and they become a regenerative fluid that's delivered to promote healing. And I'll show you some examples. Everybody understand the concept? Okay. So here's a picture, scanning electron micrograph of the membrane, right? One of these membranes. The difference between the single graft and then the dual is this is one layer and this is two layers of membrane kind of folded over on itself to be a little bit stronger. It's like double ply tissue paper. So here's a graft that has been decellularized, and then we seeded it with human fibroblasts, and those are the ones that are colored blue, just proving to ourselves that after just 12 hours of culture, this is presumably what's happening in the body. We put the scaffold in, and the fibroblasts from the skin grow over top of it. And I'll show you some pictures, gross observations. So the fluid is a room temperature fluid. It's stable at room temperature. It's acellular. We don't use the stem cells other than to culture the fluid, and then we pull the fluid off, aspirate off the fluid, and leave the cells attached on the petri dish. And so this can actually sit at room temperature for a year plus. Now we're out to 18 months, believe it or not. Slides are a little bit old. Then we made it into a shot product, so it's in a preloaded syringe, so the physician can actually just add the needle that they want and inject it. Where do they inject it? Well, they're injecting it into wound beds. They're injecting it into joint spaces for patients that have joint pain. And I'll show you some pretty gnarly wounds that we're using it for wound care here in shortly. This is a video. I've shown this video before. This is where I got it from. This is time-lapse photography. That was one mesenchymal stem cell that just broke into two, divided into two. and now it's sped up. This is a 24-hour process, or sorry, a 1-hour process that we're speeding up quickly. So what you're seeing happens in 1 hour, but now it's happening in just a few seconds. And all of this little budding that's happening are all of these release vesicles that are dumping out these growth factors and cytokines into the fluid. That's that petri dish that I showed you earlier in that cartoon picture. And so we're not delivering stem cells. What we're doing is we're encouraging the resident stem cells in the tissue to upregulate, to become active, to go through growth and proliferation signals, to stimulate new blood vessels to grow, to stimulate new matrix production. And so in a way, we're awakening the cells that are there. And the way that this is done is through a number of different molecules. So here's a list of a family of growth factors: epidermal growth factor, platelet-derived growth factor, transforming growth factor beta 1. All three of these are in this family of stimulating cell growth and differentiation. So they're going to, make the cells larger. They're going to have them proliferate, and they're going to start laying down additional extracellular matrix. All of that is necessary to heal a wound. Think about that. Whether it's a wound that happens in a joint, in a bone, in a muscle, or in skin. So we have these bioassays. Now instead of using chick eggs like we did back in the 90s, right, which is a pretty awesome assay, it worked really well, but we actually just grow human fibroblasts in culture, and we spike it with the fluid. So this is the control media. The control media on the left, the gray bar, and then the regenerative fluid, or this axolotl ambient fluid, spiked into the culture. And after a period of time, this is a 24-hour assay, we see a twofold increase in metabolic activity of those fibroblasts. Those little blue cells that I showed you on that scaffold? So in the presence of the fluid, they upregulate their activity. They increase their cell cycle. This is a preclinical model. It's a wound model. This is in a mouse. And this was a full thickness wound that was created. And the left was treated with control standard of care, like a dressing. And after 2 weeks, 14 days, we had fibrosis, but no restoration of a new epidermis. And with the membrane and the fluid injections, we restore the new epidermis in this mouse model. So this gives us a lot of confidence that we can go into clinical applications and see benefit. Here's another bioassay. When we inject these into the joint, like in an osteoarthritic joint, the question is, what's going on inside that joint space? Well, we know from this work, these are chondrocytes in culture that are human. So those are cells that make cartilage. And they upregulate their activity. So the green bars show a 20% increase in just 72 hours that's maintained over the control condition. So chondrocytes are upregulated, not just fibroblasts. Another cell type, synovial sites. Synovial sites are found in the joint space, and they make synovial fluid. And so if we look at how patients are responding when we inject this fluid into their joints, like their knees or their ankles or their hips, they have better range of motion, they have less pain, restoration of daily function, and presumably what we think is happening based on these data is that maybe chondrocytes are being stimulated, as well as an increase in synovial fluid production due to the response of these cells in the presence of the axolotl fluid, or the regenerative fluid. So you can see a statistically significant increase at 24 hours. Again, almost 60% increase at 96 hours. Okay, so what else is going on? Well, we've tested this fluid for angiogenesis. And again, instead of using that chick choriontonic membrane, we just culture endothelial cells. We take human endothelial cells and we grow them in culture, and we know that this fluid has fibroblast growth factor, angiopoietin-2, and VEGF in it that stimulates blood vessel development. We also know that it has MMP9, which stimulates remodeling of the matrix, and this is a diagram that shows how a wound remodels. You guys remember that? So how these wounds remodel over time, when we get into the final phase of wound healing, we've got tissue remodeling, and MMP9, which is an enzyme, helps to promote appropriate wound contraction and remodeling. So if we look at angiogenesis and we look at culturing these endothelial cells instead of cracking an egg open and putting it on that chorion membrane, these are human endothelial cells that grow in culture. And what they like to do is they like to link up and form these tubes. And so it's a tube assay formation study. And if you spike these cultures that have these endothelial cells, remember, endothelial cells are the cells that line the inner surface of a blood vessel. So if you stimulate them with an angiogenic compound, you're going to promote the formation of these networks of tubes. Make sense? It's a very simple assay. And so that's exactly what will happen when you stimulate these. And the lower two images is a computer representation of the upper images, where it's starting to automatically, using an algorithm, connect the number of meshes and highlight the number of nodes. And then we can actually quantify what we've got versus just visual quality, right? So if we look at the number of nodes and the number of meshes, the negative control is just the culture media that the endothelial cells grow. And then when we treat it with the regenerative fluid, we see a 2-fold increase in the number of nodes and a 4.5-fold increase in the number of meshes, both of those being statistically significant responses. And in comparison, that's the red bar to the green bar. When we look at the yellow bar, which is the positive control, what is positive control in this assay? That's just treating it with VEGF alone. So we spike that culture with VEGF alone, which we know is a potent angiogenic growth factor. We actually only see an upregulation to this level, and the fluid is triggering a response above and beyond that. Why? Well, if you go back a couple of slides, you see that it's more than just VEGF that's present. So these angiogenic compounds are working synergistically to stimulate new blood vessels to grow. Okay? You guys with me? Everybody with me so far? Tissue remodeling. So if we look at the extent of tissue remodeling, we've got matrix metalloproteases, 1, 2, 3, and 4. So these guys are kind of the regulator to remodeling. So they inhibit a lot of enzymatic degradation of the extracellular matrix. And the point there is you don't want to remodel so aggressively that you lose all the important matrix that you laid down. So the picture that's shown here, and the way this relates, is this is from the literature. This is a paper published in 2002, and this was an article. They were looking at knockout mice. Anybody remember what knockout mice are? Who can define a knockout species?
You like take the gene out of the genome of that mouse.
So you take the gene out of the genome, and the gene that we're taking out here is a gene for TIMP1, so tissue inhibitor of matrix metalloprotease 1. Now, why are they doing that? Well, the reason that they did that was to understand if we knocked out the gene that code for TIP1, then this organism would be born without the ability to make the regulator of matrix metalloprotease. And by taking out the regulator, we looked at the phenotype. What happens in the animal? Well, this is the heart. So this is a picture. These two pictures on the left are a wild type mouse. This is a control. So this is the left atrium, and this is the left ventricle. And then they gave it an infarct. They gave it a heart attack. And so if you can kind of appreciate in the left ventricle, the LVAP, if you circumscribe the inner lining of the left ventricle, and then after an infarct, you can see it's larger. So we have an enlarged left ventricle after an infarct. That's normally what happens, okay? It's swollen, it remodels. It doesn't have its normal architecture. Well, now if we look at the knockout mice, the TIMP1, negative for both alleles, you can see at baseline the left ventricle is already larger than what it was supposed to be. And then when you give it an infarct, this left ventricle swells to a much larger degree than it does in the wild type. So this is illustrating the concept that TIMPs prevent over remodeling from taking place. Make sense? All right, so the last category of what's found in this fluid, this regenerative fluid, all of this is made by these mesenchymal stem cells. These mesenchymal stem cells are making cell growth and differentiation factors. They're making angiogenic factors. They're making regulators of remodeling. And they're making an antimicrobial. So this is myeloperoxidase. Myeloperoxidase is a very potent antimicrobial. And what it does is it's manufactured and released by neutrophils at the site of a contamination. Which cells are the first ones to show up? The neutrophil. They're the ones that deliver this antimicrobial, which is convenient. And what this myeloperoxidase does, this antimicrobial, actually it's this little guy, not the green one, but the one right below it, is, and you can see this is a neutrophil, and it is releasing this ectosome, so that's where this arrowhead is, and this inset with this arrowhead is showing this little round sphere, right where my laser pointer is, if I can keep it still. And that little round sphere contains myeloperoxidase, and it's going to dump its content. And what myeloperoxidase does is it actually serves as a facilitator of optimization of the bacteria. So it triggers the bacteria to be labeled so that the either neutrophil or a next generation macrophage will phagocytose it. Okay? So this is important for dirty wounds, right? All of this is on board by the developing environment, right? The in utero environment, because that's where all of these stem cells were initially. And so we're just harnessing that. All right, last but not least, of what's in this regenerative fluid, and then we'll get to some clinical examples, is we've got potent anti-inflammatories. So these anti-inflammatories like interleukin 10 and interleukin 1RA, this is the receptor antagonist, they drop the inflammatory burden. Okay, so what I want to do is I want to show you what that looks like graphically. So if we have this graph and we looked at chronic inflammation, we saw it do this. You guys remember that? And if we look at acute inflammation, we saw there was a phase 1 and then there was a phase 2, and then we actually had remodeling. Does that make sense? And this was out to like 360 days. And so this is acute, and this is chronic. Well, if you've got a wound, I'm going to show you a chronic wound here in a second. If you've got a wound where your neutrophils, right? Oops. Oh, that looks horrible. Right? And then these are macrophages. You guys remember that symbol? So the neutrophil response comes up, comes down. Macrophages come up and come down. And the up and down triggers healing. If you come up and these macrophages stay elevated and it never comes back down, you never actually have wound repair or wound resolution. So what's interesting is that this regenerative fluid, this regenerative fluid helps to lower inflammation. So maybe what it does is it takes this line and helps to settle it. And then you push from a chronic situation over to getting over the inflammatory trigger, and now you can promote regular healing. Does that make sense? So by attacking interleukin 10, or attacking inflammation with interleukin 10 and interleukin 1 receptor antagonist, but not broadly blocking inflammation completely using a corticosteroid. You guys remember that pathway with the corticosteroid? How it prevents the formation of arachidonic acid and obliterates all inflammation? This is more targeted muting of the inflammatory response, not broad-based elimination of inflammation. Do you understand the difference? So what we're seeing in the field is this is a really good way to, in a healthy way, lower inflammation, but not completely eliminate it. Oh, and I just wanted to point out, in case you didn't believe me, look at this. What is this cell? That's our macrophage. See the little symbol? So, all right. Questions? Okay. So we've got a couple of clinical examples as we wrap up today. So this was a wound that happened in a patient who had fallen. 47-year-old, so not elderly, say it that way, right? Definitely not young, middle-aged patient, but she broke her ankle in October of 17, and she laid in the floor of her house for a couple of days before a neighbor actually hurt her, okay? Pretty bad ankle fracture, so they repaired her. They repaired the ankle fracture and they put appliances in, and it became infected. The wounds dehisced. That means the sutures pulled apart and the wound was opened up, and now the appliance got contaminated and got infected. And so this is how we saw it almost a year later. So there is a metal implant here. This is the chronic infected wound after it's been repaired, but now it's been chronically open. So it's one of these situations on the right side with chronic wounding. And it's been open now for almost a year. So we packed it full of the membrane. We injected the fluid into the wound bed and into the wound margin on the edges. Every picture that you're going to see, there is a new membrane and new fluid that's been treated. So this is a releasing incision up here. So this is the original wound here. And not me, I say we, but it's actually the surgeon, cut a new arc so they could approximate this and bring this together because it was so swollen and so infected they need to have a releasing incision to actually pull that tissue over. Does that make sense? So you're going to see it gets a little bit worse before it starts getting better. Here it is at the end of October from August, so almost 3 months later. Here it is in January. And then the surgeon basically picked this scab because they wanted this to close completely. And this is just this month, and you can see that it's fully repaired. Again, from here to here, and some of you are thinking, wow, it took that long to go from here to here. Yeah, but this thing had been open for almost a year like this. So this is what we're doing today in medicine, is we're treating these kinds of wounds. Here's another example. Not with skin. This is a radiograph of an ankle fracture in a 39-year-old male. So this is the medial aspect of the fibula on the patient's right side. You guys catch that? So this is the fibula, the medial portion. This is the patient's right. So it's, patient's looking at you. You guys remember that? Anatomical position. So this is at baseline of the fracture. They rolled their ankle, broke their ankle, stepped in like a gopher hole at a picnic. These insets are a little easier to see. You can appreciate the fracture right here. This is 4 weeks later. Fracture's gone, completely healed. Bone typically takes 6 to 8 weeks to heal. In a patient at 39, probably 8 to 10 weeks at the ankle, maybe even a little bit longer, 10 to 12 weeks. Especially if they're load bearing. Patient was put in a boot, that was it, walked around on it, and 4 weeks later it's totally healed. Why? What do you think mechanistically from a fluid standpoint that's in it that's causing this type of response in bone? What brainstorm? Let's go back. What is it that you think that's causing this kind of response in skin of what you know that's in the fluid? What are some ideas? Yeah. Angiogenesis. Okay. So if you want to bring in new tissue that has a higher metabolic demand, You need to provide resources. You have to provide oxygenation, right? Otherwise it won't heal. Angiogenesis, we know it's angiogenic. What else? To go from here to here, did you have to stimulate new cells to grow and divide? Yeah, so cell growth and differentiation signals. Remember that list of EGF, PGF beta? Do you remember those? TGF beta 1? How about matrix remodeling? Is there any remodeling of the matrix happening? Like in this phase of the graph? Absolutely. How about your MMPs and your TIMPs? Okay, now, same question. What's going on here? Bone versus skin. Are they some of the same mechanistic processes? Do you need to have new blood flow into the bone in order to heal it? Absolutely. That's one of the reasons bone heals so well, is it's very vascularized. You guys know bone bleeds if you cut it, right? If anybody been in orthopedic surgery and they cut through a piece of bone and you're like, oh my gosh, it's like bleeding like stink. It's crazy. So it's very well vascularized. That's why it heals so well. In contrast, name a tissue that's near bone that doesn't heal well. Cartilage. It's not very well vascularized. So if you promote a vascular supply, are you going to promote bone healing? Yes. Do these bone cells, these osteocytes and osteoblasts, are they influenced by cell growth and differentiation signals? Just like a fibroblast in skin? They absolutely are. I didn't show you any bioassay data like I did with fibroblasts, but would you suspect or would you hypothesize that if we put osteocytes or osteoblasts in culture, would they increase their division rate in the presence of this fluid like we saw with fibroblasts? Yeah. So does it make sense how this stuff is working? Okay. Where I'm going with this picture is this cartoon drawing that I drew, this sketch. And we've seen this before, right? This is adapted from Clark's text. And we've got our early phase, we have our late phase, and you can see and appreciate superimposed over these different phases the different stages of skin wound healing. Well, we can do the exact same thing with bone healing. And you could do that with joint space, you could do that with muscle, right? You could do that with any tissue that you want to promote regeneration and healing in. So you can kind of appreciate here, we've got inflammatory cells early on. Look, we've got vascular cells. This is bone. Vascular cells. Here's our chondrocytes. They actually need to become hypertrophic, meaning they need to enlarge. Okay? We need to stimulate some mesenchymal progenitors to form those osteoblasts, which are the precursor cell to an osteocyte. And then we want the chondroclast and the osteoclast to influence remodeling. Right? The osteoclast is the one that's kind of like a macrophage. It kind of chews up the bone and remodels the bone. You guys remember that balance between building bone and breaking bone down? So two different sites of healing, but two very similar mechanistic processes. All from a fluid that's being used to treat that is acellular. It doesn't have stem cells in it anymore. Okay, so this particular technology is leveraging an acellular product, not a stem cell therapy. So there's a lot of buzzwords out there about stem cell injections and stem cell therapy. That's not what this is. This is taking the products the stem cells make, but not the stem cell itself. Okay? All right, so where's this stuff being used? Well, there's 5 products on the market. 2 of them are membranes, 3 of them are fluid. There's a frozen fluid and 2 room temperatures, one that's the vial and one that's in the syringe. And you can appreciate all the different places in the body since 2017 that has been used to treat. So we've got ankle, spine, shoulder, knee, making up, maybe a good 45%, 40% of the usage. Then down in the foot, wound is actually only a small sliver at 3. Our suspicion, though, is a lot of miscellaneous soft tissue and even some of the non-reported are actually wound cases, that they're not coding as wound cases. But the next generation of these products is to go after more complicated regulatory submissions. So going after IND work to get what's called a biologic license application, and we can pick one of these particular target areas of focus, and then that's where we'll focus our clinical studies on. Make sense? Yeah, question?
Just wondered if you could comment on how accessible these are. Are these accessible through insurance, or are they?
Yeah, it's a good question. So are these technologies accessible through insurance? So the membrane products tend to be reimbursed now. The fluid products are too early stage, where it's a lot of out-of-pocket pay for patients. But companies are going through the process of getting approval so that insurance companies will start covering them. But right now, which is very common, early stage technologies are usually out-of-pocket pay. Question here, and then maybe there's one over here.
What would it cost for like a treatment with the axolotl like ambient fluid, like in that fibula fracture?
Yeah, so it depends on where the patient goes. Typically, the physicians are charging anywhere between like $1,500 upwards of like $3,500 for an injection. That's what they charge for their clinic, their time, and the product. The product doesn't cost that much, but that's about what it's costing. And it varies from one clinical facility to another, and then what product they end up using. Yep.
So is it very common for athletes to get this sort of treatment so that they can heal faster?
Yeah, so we have a lot of athletes that use these technologies, and they all began with this platelet-rich plasma craze, where athletes were getting blood draws, spinning down their plasma, their blood plasma, where you find a lot of these same types of growth factors and cytokines, and they were re-injecting that blood plasma like into their knee or to like a torn muscle. Again, it's an acellular therapy. They're pulling their blood, spinning it down, and just getting the growth factors and cytokines. And so elite athletes, it works really well when they're in their teens or 20s, because the cellular machinery that's making those growth factors is the age of the patient. But if you're treating, a 47-year-old, 77-year-old, or an 87-year-old, and you pull out blood plasma, you're getting growth factors and cytokines that are made from cells that are the same age of that patient. Does that make sense? And so that's why we went to these MSCs that were coming from very, very young tissue. There's a lot more control over biologic variability when you have a single target tissue that's always the same age. It comes from different patients, there's no question about that. But then we can screen down, like, we don't take donations from mothers that are over the age of 32. And of course, it's got to be disease-free, and it can't be a pregnancy that has comorbidities associated with like maternal diabetes, where there's a complication there. Usually the baby's fine, mom's fine, but birth weights are off and there's other physiology happening. So we can kind of narrow it down by just using just one cell type. Was there a question over here?
One more question.
Yep, sure. One more question.
So do you reimburse the mothers? Do you buying their placenta?
So the way that it works is with human tissue, even like cadavers, you can't create a business where you're buying and selling human tissue. So what happens is people donate the tissue for medical or research purposes. And then those companies have costs associated with processing it. So they can charge for their costs, but they can't charge to sell a hunk of human flesh. Does that make sense?
Yeah.
So the cost that you have as an organization is you're buying like a product of tissue, but you're paying for all of the things, like you got to pay the hospital for the staff to harvest it, you have to pay for transportation, you have to pay for processing, dissecting it out, you have to pay for all of the screening and testing. So there are costs associated with that, but you actually technically aren't paying for the tissue.
So the mothers are donating it?
They're donating it, yeah. They're donating for the purposes of medicine or for science, yeah. It's not really any different than being an organ donor. Like if you're an organ donor, your tissue is actually are used in other patients, and there's a cost associated with it, but nobody's buying and selling your kidney. But to put your kidney in a styrofoam box and ship it is actually pretty expensive. You know what I mean? So someone has to cover those costs. It's a great question, because you always kind of wonder, like, is there like some, interesting industry going on of buying and selling human tissue? All right, this is all I have for you guys today. We're out a little early. Wednesday, we're going to dive into the immune section, okay? See you guys then.